Thank you so much for inviting me. And on top of whatever you said before, I blush very easy. The sinonasal tracts is the location for a garden variety of benign and malignant entities. Well, this is obviously due to anatomic complexity as well as the variety of tissues compressed in such a small space. So for today, I will tackle just the sinonasal carcinomas, and even from that, since it's such a broad field, I will go over some entities, and mainly I will give you a preview of the upcoming head and neck WHO 2017. So some new entities which made it in the new WHO for head and neck. Okay, so the sinonasal tumors comprise less than 1% of all neoplasms and make up 3% of the upper aerodigestive tract tumors. The most involved sites are the maxillary sinuses, 60%, followed by nasal cavity, 22%, ethmoid, 15%, frontal and sphenoid sinus, each about 3%. In terms of origins, majority, about half of these are epithelial, followed by mesenchymal, 30%, neuroectodermal tumors, 15%, and unknown origin, or we assume from stem cells, about 5%. Within the epithelial tumors, 55% account for the squamous carcinoma, the conventional type, so I'm not going to cover that. So in terms of origins, maybe you are already wondering where the accent comes from. This is home for me. This is a map of 15th century Europe, and this is Transylvania, so I'm from Romania originally. So, and at that time, as you can see, the Ottoman Empire was broadly expanding and pushing their borders. Anyway, they were always stopping here of Transylvania due to this guy, the impaler, and I have no affiliation with him, so no final relationship with commercial interest. So anyway, background. So diving into the umbrella of undifferentiated carcinomas, let's start with the SNUC, the sinonasal undifferentiated carcinoma. These are high-grade malignant epithelial tumors of the nasal and paranasal sinuses, uncertain histogenesis, with or without neuroendocrine differentiation, but definitely without evidence of squamous and glandular differentiation. So usually they present as unilateral masses, with the symptomatology, which you know even better than I do, nasal obstruction, epistaxis, pain, proptosis, visual disturbances, as well as cranial nerve pulses. Histology will show lobules, nests, or even sheets of malignant cells within the submucosa. So here we have nicely the mucosa. So a low power of a SNUC, showing the malignant cells arranged in a sheeted pattern, or more of a lobular or island-like patterns. Anyway, what's important are the nuclear features. The SNUC have the classical large nuclei with very prominent nucleoli. So that's always a good tip off on morphology. Another thing to notice is that it has well-defined cellular borders, a lot of apoptotic bodies, and necrosis and mitosis. These are common findings in SNUC. Well, as you know, despite aggressive management, the prognosis is not that great for these tumors. Another entity within the umbrella of undifferentiated carcinoma is the sinonasal nasopharyngeal type undifferentiated carcinoma, also known as a lymphoepithelial carcinoma. The histology will show, again, islands or lobules, or even sheets of so-called syncytial pattern arranged cells. You notice we call this fascicular nuclei, open chromatin, and the cells have this indistinct cell borders, so there is this buzzword syncytial pattern. Anyway, these islands of cells are embedded in a very prominent lymphoplasmacytic infiltrate, so you see the background, a lot of lymphocytes and plasma cells. In this case, where the islands are well defined, this is called a Rego pattern. But sometimes the cells might be spindly and streaming, or even more isolated individual cells with ill-defined borders. This is the Schmink pattern. A nightmare to, you have a bed frozen, and then you have single isolated cells and to make the diagnosis. Anyway, in these cases, a keratin stain is always very helpful. We have it at Anderson within the last 3 years, the rapid keratin, so it may take about 30 minutes at the time of the frozen, but it can be done whenever the pathologist is in doubt on frozen. So SNUC similar to, sinonasal undifferentiated carcinoma, similar to nasopharyngeal type undifferentiated carcinoma, is about 80% positive for EBV. So that's an example of an EBER in situ hybridization for this. Similar to NPCs, distinctive features such as well-known geographical distribution, Southeast Asia, etiology, EBV-related, histopathology with the lymphoepithelial type carcinoma, as we just went over, and obviously a good response to therapy, radiation. Similar lymphoepithelial carcinoma can be seen in other sites, such as salivary glands, lung, thymus, bladder, and gastric. And all this may be as well EBV related and positive on in situ hybridization for EBER. So just a quick comparison, mainly for trainees. SNUC rare in nasopharynx, but we've seen a couple of cases not related to EBV, not responsive to XRT. In contrast, the sinonasal nasopharyngeal type carcinoma, strong association with EBV and responsive to radiation. So another entity, actually, which this time made it into the WHO, it got own ICD code, so you will see that the pathologists actually are now entitled to put this diagnosis with the right ICD, is the so-called NUT carcinoma. It used to be called NUT midline carcinoma. It's been described first time, I believe, in 2007 or 8. But anyway, the new WHO dropped the midline word, so it reads just as NUT carcinoma. So a small percentage of the upper aerodigestive malignancies are associated with translocations which involve the nuclear protein of testis gene, the NUT gene, on chromosome 15q. And this gene has two partners in translocation. One is the BRD4 gene on chromosome 15, and the other one is the BRD3 gene on chromosome 9. So just a quick molecular genetics, again showing the BRD4 on chromosome 19 and BRD3 on chromosome 9. Both both partners for the NUT gene on chromosome 15q. Both BRD3 and BRD4 are part of the bromodomain proteins, which are binding transcriptionally active chromatin. So generally, patients with NUT carcinomas frequently present with MAX-related symptoms, including the vena-cava syndrome when the tumor is in the mediastinum. And most of these patients will have metastasis at the time of diagnosis. So this is from a paper from 2000. which was the largest series published at that time, about 22 cases. As you see, the age is ranging from 3 up to 78 years old. At that time, there was a slight predominance between females, and the tumors were equally located in head and neck and thorax. So within the head and neck, most of these were in the sinonasals, followed by nasopharynx, larynx, epiglottis, orbit, and in the thorax, mainly mediastinum and thymus. The survival is really grim. 15 out of 16 patients which had follow-up were dead of disease within 2 and 37 months of follow-up. So just an example of a NUC carcinoma, which involves the left orbit and extends into the cranial cavity. The histology, few things. The cells are usually very small, have little cytoplasm, but the nuclei tends to be monotonous, again with fine to vesicular chromatin, sometimes prominent nucleoli, again similar to SNUC, mitosis, apoptotic bodies, and necrosis are seen. On rare occasions, and that's very helpful for pathologists, not on rare occasions, very helpful for pathologists, is a squamous differentiation, which is always a good tip-off. And this squamous differentiation can be seen sometimes as very abrupt keratinization, reminiscent of the Hassel corpuscles seen in thymus. So just an example of a NUC carcinoma, as you see, small round blue cells, monotonous, and again here you have abrupt keratinization, similar to the Hassel corpuscles. Here it's more keratinization. Again, higher power, you notice the cells very monotonous, some of them prominent nucleoli. Again, apoptosis, mitotic figures are common findings. Morphologic mimickers, full laundry list, starting with the basaloid squamous carcinoma. Luckily, for this entity, we have help with the HPV stains. Lewis and Peanut with the CD99 helpful staining. The extragonadal germ cell tumors, again with adequate markers for germ cell tumors such as FLAP, OCT34, and beta-HCG. Lymphoma leukemia with leukocyte common antigen, positive and helpful. Nasopharyngeal carcinoma, CDD, poorly differentiated squamous carcinoma, esthesios, small cell carcinoma, and SNUC. So a full laundry list, the same differential for other small round cell tumors. But as a general rule, in order not to miss NUC carcinoma, any poorly differentiated monomorphic midline neoplast that does not stain for a lineage-specific marker should be considered for a NUC rearrangement testing. And we have different diagnostic tests. So there is an RT-PCR testing available, there is a FISH, and even very helpful for us, for pathologists, there is a monoclonal antibody called a NUC antibody, which is a nuclear stain, since transcription factor, and this has a very high sensitivity and specificity, so 95 and 98%. So we use this all the time with our So to summarize, NUC carcinoma, highly aggressive, incurable, actually a form of squamous carcinoma that's associated with a chromosomal rearrangement of the NUC gene and has two specific fusion oncogenes, BRD3 NUC and BRD4 NUC. The karyotype of this carcinoma is rather simple compared to other squamous carcinoma, thus suggesting that's arising through shortcut, epigenetic or genetic shortcut of the squamous carcinoma. Right now, it's diagnosed by an immunohistochemistry stain with an anti-NAT antibody. Just a few relevant things. The fusion transcript actually blocks differentiation of somehow which is required for the squamous differentiation. And there are two histone deacetylase inhibitors and bromodomain inhibitors which actually reverse the effect of the fusion oncogene through mechanisms that still remain to be elucidated. This is an orphan cancer, and now there is a resource through the International NAT Registry. Right now there are about 80 patients, as far as I heard, enrolled in this NMC registry. So future issues are targeted inhibitors, bromodomain inhibitors. I know they do have a trial at Anderson as well. So I had 2 cases last week. What are the odds?
That's unbelievable.
Yeah, I know, it's coming in waves. Probably I've seen so far about 8, but yeah, they do have a clinical trial. Yeah, I don't know if you know Sarina Pihapol.
Yeah.
Yeah, she's running.
So one of those cases is probably the young woman who I sent her.
Yes. I blank on her name, Katie or something. Yeah.
But they take HIPAA out here very seriously.
Right. So yeah, I mean, it's funny. I think we've identified 3 cases in about the past 2 or 3 years. One, your trial was open. The others,
The one in Boston.
they're basically too sick to make it. Because as you say, it's very aggressive.
Thank you for sending a great case. So another entity had the neuroendocrine carcinomas. These are, I'm not going to spend too much time since they are very similar to other organs, mainly the lung. So you have well differentiated, also called carcinoids, moderately differentiated neuroendocrine carcinoma, aka atypical carcinoids, and then you have the high grade, which are falling under the category of small cell neuroendocrine carcinoma. Until this new WHO, we did not believe in the large cell neuroendocrine carcinoma of the sinonasal tract, but this has made it, and now it's a separate entity as well. So this is an example of a small cell neuroendocrine carcinoma, similar to what you see in lung or other organs, small blue cells with molding and crushing artifact, really high grade, high mitotic rate, necrosis, and so forth. So very similar to other organs. Speaking of neuroendocrine differentiation within the sinonasal tract, obviously there is some histological overlap, but anyway, bottom line, based on the amount of neuroendocrine differentiation, we can subcategorize this into olfactory neuroblastomas, neuroendocrine carcinomas with the small cell type, and SNUC. And obviously the natural history and the biological behavior is very variable between these groups of tumors. Therefore, a correct morphological diagnosis as well as combined with grading and staging are very important for prognostication. So in a nutshell, more graphic, just for the trainees, if we want to make it really simple. So sinonasal tumors with neuroendocrine differentiation based on origin are split into neuroectodermal, such as olfactory neuroblastomas, and epithelial, which epithelial divided according to differentiation into well and moderate differentiated neuroendocrine carcinomas, as I said, carcinoids and atypical carcinoids, or poorly differentiated neuroendocrines, which based on the cell size can be divided into small cells and large cells. So this is still debatable, but you know, or at least at Anderson, we consider SNUC actually a large cell neuroendocrine carcinoma. I know it's a lot of controversy in this field, and pathologists really go wild on this SNUC, but I mean, that's our Anyway, I borrowed this slide from Dr. Ihab Hanna just to illustrate the Anderson experience and what I said, what's important in having the right diagnosis. So this, for instance, you'll see the overall survival for olfactory neuroblastomas, and actually these are the low grade. Then in between the neuroendocrine carcinomas, and this includes the high grade olfactory neuroblastomas, that's Hyams 3 and 4. I'm not going to get into the olfactory because it's too much to talk. So these have similar behavior with the SNUCs, and really low with poor outcome, the small cell carcinoma. So small cells, about 28.6 survival, SNUCs and neuroendocrine pretty much equal, 60s, and then low-grade olfactory neuroblastomas up to 93, 5-year overall survival. So just a quick buzzword for the training. A good way to remember for the boards, the small round blue cell tumor differential diagnosis is Mr. Sleep with melanoma, rhabdomyosarcoma, SNUC, lymphoma, esthesioneuroblastoma, Ewing's, paraganglioma. So for pathologists, a good diagnostic algorithm for all these undifferentiated cell-based tumors, always start your workup for the case with 4 antibodies. Keratin, neuroendocrine marker, synapto is usually the best one, followed by chromogranin. Muscular marker, desmin, and then a melanoma marker, PANMEL or melanin or whatever you have in your lab. So then based on the keratin expression, so keratin positive, all the other markers negative, roll in a squamous carcinoma or SNUC. Keratin positivity combined with a neuroendocrine marker, obviously a neuroendocrine carcinoma. Just to make you aware, some of the rhabdomyosarcomas, which are obviously positive for desmin, may show some keratin positivity as well. Similar melanomas may also show on rare occasions some keratin positivity. So these are two things which will not sway you from the diagnosis. So then keratin negative, along with positive for neuroendocrine markers, classic olfactory neuroblastomas, desmin positivity, along with some other muscular markers such as MyoD1 and myogenin, classic rhabdomyosarcomas. If you want, you can do further molecular and further characterize them. For instance, the alveolar type has a classic translocation, the PAX FKHR. Melanin positivity, classic for melanoma, and CD99. Fly1 along with the classic translocation EWS Fly1 for Ewing's and peanut tumors.
Well, melanin, did you need melanin or did you need melanoma markers like HB45 or things like that?
Melanin or melanoma markers depends if you use a cocktail or just HB45 or melan A or tyrosinase, but usually we do use So moving along into the sinonasal adenocarcinomas, nothing has changed much compared to the prior WHO from 2005. So dividing them, so SNUC sinonasal adenocarcinomas divided into salivary type, which are similar, so basically identical to what we see in major salivary glands, such as enoid cystic basal cell identical histology, and the other group, the non-salivary type adenocarcinomas, which are divided into intestinal type and non-intestinal type, each of them with low and high grade. So the intestinal type sinonasal adenocarcinoma, identical histology to what we see in the colonic adenocarcinoma, or even they can show up with histology similar to normal enteric mucosa, so not having this classic colonic appearance, but most of the cases will be really the same histology like colon adenocarcinoma. These are viewed as a higher grade tumors, usually invade the bone, and a lot of interest has been elicited since this seems to be related to some occupational hazards, so a lot of cases linked to some occupational exposures like dust, wood dust, and leather pigments and so forth. So very common mainly in Italy and in Europe. Majority of this occupational related intestinal type adenocarcinomas mainly occur in the ethmoid sinus, while the non-occupational mainly seen in the maxillary and the sporadic types. So these enteric type adenocarcinomas occur as a result of intestinal metaplasia. So here is really a nice example of the normal respiratory type mucosa ciliated. Now you see a nice transition to the enteric type mucosa. And really a good diligent sampling will show you a nice transition like in this case. So you have the normal mucosa, respiratory type mucosa, then transitioning into the intestinal type metaplastic mucosa, and underneath you have an intestinal type adenocarcinoma. So it's just a matter of sampling how many sections you take and so forth, but you should be able to see with an adequate number of sections a nice transition from respiratory mucosa to intestinal type mucosa. So even better if you do an immunostain, for instance, for CK20, which is the classical marker for intestinal type mucosa, you'll be able to spot the metaplastic foci within the respiratory mucosa, which is positive for keratin sulfur. So this is the normal mucosa, positive for keratin sulfur, while the metaplastic foci you see here positive for CK20. So the enteric type adenocarcinomas, like I said, are positive for both keratin 7 and keratin 20. So notice again the normal respiratory mucosa, which is negative for keratin 20. Compared to colonic adenocarcinomas, the rate of RAS, KRAS, and HRAS mutations is much lower, about 10-15%. And the other category, the sinonasal adenocarcinoma seromucinous type. So these are tumors which do not show the morphology of classic salivary type and do not show the morphology of intestinal type. So it's sort of, in between category. Anyway, these are thought to be a much lower grade compared to the intestinal type. They will show coalescent, rather monotonous small type glands, so arranged in a back-to-back fashion with very little intervening stroma, somehow similar to endometrial type adenocarcinoma, if you wish. But yeah, just to contrast, histology of non-intestinal with intestinal type adenocarcinomas. So in intestinal type, I forgot to say you have this classic comedal necrosis, which you don't see in the seromucinous type. So these are better behaving and better histology, not so aggressive. So on top of everything, the seromucinous non-intestinal type keep to the normal phenotype of respiratory mucosa, being positive for CK7, as I said, and negative for CK20. So that's another helpful stain if you are in doubt just by morphology. Nice review by Lorente from 2014. He summarized, well, obviously the list is much larger, but that's a pretty narrow summary of the genetic alterations seen in the intestinal type adenocarcinoma and squamous, primary squamous sinonasal carcinomas, and with the main genetic aberrations and the possible targeted therapeutic agents. As you notice, EGFR overexpression similar seen pretty much in both the intestinal type and the squamous type carcinoma, with targeted cetuximab and TKI inhibitors. Interesting, HER2 overexpression really low in sinonasal squamous and not present in intestinal type. KRAS mutations, I already mentioned, maximum of 15% of the intestinal type will have these mutations, compared to a null percentage seen in squamous type. Interesting, NF-kappa B encoding genes are quite high in intestinal type and have not been described in sinonasal squamous. And another interesting genetic aberration is the COX-2, up to 60% described in intestinal type, with a much lower percentage in sinonasal squamous. And again, the famous castle of the Dracula, and I do have no affiliation, as I said. You missed my origin.
I'm on call this week. Sorry.
Yes.
So thanks, guys. Nice, the head and neck faculty. So those two adenocarcinomas, the seromucinous type, I think especially the intestinal type, that doesn't metastasize, correct? That's the one that doesn't metastasize, is that right?
I don't think I've managed the case.
Intestinal texture tends to be very much more indolent and local.
Right, like locally aggressive, but not, for some reason, not.
They're hard to take care of, but they do well.
Right. So then I was just wondering if it's known, I mean, as far as I knew about the KRAS mutations, it seems pretty low RASopathies. They're low for the RAS mutation. I wonder if that's a least possible reason. It's just not that, it's not that aggressive, maybe because of the KRAS mutation. Is it known in your literature about that? Like why it's, there are some favorable cancers in some ways.
I'm not sure if KRAS is responsible for rather, I don't want to say indolent because locally they are very aggressive.
Yeah.
It's just
there's bone erosion like you
yes.
showed, so.
Right. We've seen a couple of cases with neck mets,
Is that right?
Yeah.
There are just so many targets. I mean, it's hard to tease out maybe the impact of KRAS given.
No, I'm just wondering.
Yeah.
Just putting it out there.
Yeah.
Well, coming to the really new and hot stuff, so upcoming entities in the new WHO. So is the, I know, a very long title, basaloid squamous carcinoma with adenoid-like cystic features. I don't know if you came across this diagnosis. Also, HPV, known as HPV-related carcinoma with adenoid cystic-like features. It's lumped under the non-keratinizing squame in the new classification, but probably within the next 5-6 years will be an entity by itself. So what's interesting, it is related to HPV type 33, while HPV 16 and 18 are negative. The It's exclusively described within the nasal cavity and paranasal sinuses. Grossly, the tumors have nothing really special, kind of flashy appearance. They tend to undermine the normal appearing sinonasal mucosa. The microscopy will show a very similar pattern to enoid cystic, so basaloid cells growing in solidness, focal cribriform structures, similar to cylindromas, if you want, even in the adnexal tumors, microcystic spaces, so it's very reminiscent to enoid cystic. Even the nuclei tends to be angulated and hyperchromatic, similar to what we see in enoid cystic. What's interesting, also squamous differentiation, it's not seen within the invasive component, but there you might be able to see a squamous dysplasia of the overlying epithelium. So that's just an example I had about 3 months ago. A nasal tumor at low power. I mean, everybody, if you get this unfrozen, boom, it's an enoid cystic. So you have a nice cribriform or Swiss cheese pattern, tubules, whatever you want to call it, basaloid look. Anyway, a closer look, again, microcystic patterns, microcystic spaces, more tubules. The nuclei, some of them are angulated, so very, very compelling for enoid cystic. Even the phenotype, so P16 diffusely throughout positive, and now you are starting to contemplate a basaloid squamous carcinoma. On top of everything, P63, which is a very good, reliable marker for squamous cells, but also for basal cells, but also myepithelial cells. It's diffusely positive. Which was always for us a savior, always used for enoid cystic, will show in this case is diffused throughout positivity. And HPV cocktail, the high-risk HPV cocktail, which includes 16, 18, 31, 33, and something else, two other rows, will show this, patchy positivity. So not the really nice positivity which we see with the conventional 16, 18 positive non-keratinizing tumors, but it's still there, definitely. So if you go ahead and do an RT-PCR, a PCR for HPV, you'll come up that these tumors are positive for HPV type 33. So another upcoming entity, which is lumped under the category of SNUC, so Sinonasal Undifferentiated Carcinoma. I will illustrate the next 2 cases. So this was a lady coming with a huge mass involving on all 3 cuts, involving her right frontal sinus, compressing the orbit. So, and she presented with proptosis and diplopia. A generous biopsy taken through an endoscopic approach showed a hypercellular tumor at low power. You'll see it's obviously aggressive. We already knew from imaging invading the bone. Basaloid appearance, again, slightly higher power will show a basaloid appearance, right, with a comedonal necrosis. If you'll go a little bit even higher power, you'll spot 2 different cell populations. One cell population will have the classic nuclei, which we usually see in sinonasal undifferentiated carcinoma. So large nuclei with very prominent nucleoli. So that's one population. Then another population, it's more basaloid, similar to what we see in non-keratinizing squamous carcinoma, and another another good finding is the comedonal necrosis, again, which is seen more common in non-keratinizing squamous carcinoma. So again, cells with very prominent nucleoli. Workup will show diffuse keratin positivity, some degree of neuroendocrine differentiation with synaptophysin possibility, again some p63, so compelling for squamous component. So nobody has a problem diagnosing this, and back in the days we always had no doubt. This is a sinonasal undifferentiated carcinoma. Anyway, a little bit of additional workup will show a loss of P10 expression and also loss of INI1 or SNUC-P1. So these are tumor suppressor genes, so an INI1 basically should be present in every single nucleus of normal cells. So here we have a nice internal control with the endothelial cells. So as you see, there is a complete loss of INI1. That was another case I received maybe a month apart from the previous one. A man with anosmia presented for a second opinion with a mass in his nasal cavity, and he was also a status post segmental mandibulectomy for resected metastasis in his mandible. So that's a quick look at his pathology from the resected metastasis. Again, straightforward non-keratinizing squamous carcinoma, if you want. And again, this is his sinonasal nasal tumor site. Similar non-keratinizing squame, and also you'll see other cell population with very prominent nucleoli. Again, is this a SNUC? If you go ahead and you run an INI1 staining, you'll see a complete loss of expression. So this is another entity, the so-called SNUC-P1 IN1 deficient sinonasal carcinoma. It is lumped under the category of SNUC, but again, probably in 2-3 years will be an entity by itself. A few words about the SNUC-P1. This is a tumor suppressor gene. As I mentioned, it's a gene product. It's expressed in every single nuclei of normal tissue. The inactivation of SNUC-P1 has been linked to tumors which will share this so-called rhabdoid cytomorphology, and that's quite, this list of rhabdoid tumors includes the atypical teratoid rhabdoid tumors seen in the CNS, malignant rhabdoid tumors of the kidney, soft tissue epithelioid sarcomas, renal medullary carcinomas, myepithelial carcinomas, as well as epithelioid malignant peripheral nerve sheath tumors and extraskeletal myxoid chondrosarcomas. So I guess I made you totally dizzy, but anyway, a new addition to the rhabdoid tumor is the SNUC-P1 deficient sinonasal carcinoma. So the SNUC complex has been involved in several types of cancers. Just a very brief overview on these genes. So for instance, SNUC-A involved in pancreatic cancer, medulloblastoma, lung adeno, and Burkitt's. SNUC-B, as I said, in rhabdoid tumors. SNUC-C in colorectal cancer, prostate cancer, and cervical cancer. SNUC-D in breast cancer. And again, SNUC-CC2 in gastric cancer. So a garden variety of cancers. So the entity has been introduced back in 2014, September, in the American Journal of Searchpath. Back-to-back two papers, the German group from Erlangen. They were actually the first one to report, but fortunately fortunately or unfortunately, they were published in the same journal back to back with the Hopkins group, which at that time had 9 cases, so a total of 12 cases. We looked at our experience, and we published almost a year after another 4 cases added on. Bottom line, as I said, these carcinomas are growing as epithelioid nests in the submucosa. Sometimes they tend to extend down to the seromucinous ducts and exhibit a more papillary or pseudopapillary growth, mimicking the Schneiderian papillomas. Again, tumor necrosis, mitotic rate, it's commonly seen, frequent bone invasion. At cellular level, some rhabdoid or plasmacytoid cells may be seen, and that's always a good morphological tip-off. But what's more important, they will have this prominent nucleolus, which is classic for a sinonasal undifferentiated carcinoma. In terms of immunohistochemistry, that's a very classic immunophenotype, so complete loss of SNUC-P1, as well as a stronger keratin expression. They may show some focal neuroendocrine differentiation with synaptophysin, as well as squamous differentiation with a P63 and P40 or P16. Usually negative for rhabdo, for smooth muscle markers, for rhabdos markers like desmin, and they are negative for NUC, if you are wondering, negative for HPV as well. So differential diagnosis, already alluded to, is the non-keratinizing or basaloid squamous carcinoma. SNUC, generally now, SNUC is regarded as a diagnosis of exclusion, and we try to tease out, different entities. So SNUC-P1, it's one of them. There are a few others which will separate from SNUC. Maybe I'll come next year and update you on that.
Before the in-service
Yes.
awards.
Epithelial carcinomas as well and epithelioid sarcomas are always in the differential. So this was our series. We looked at 256 cases combined, so sinonasal, head and neck and thoracic, so 240 cases within the head and neck, which had basaloid or rhabdoid morphology. As you can see, covered pretty much everything from SNUC, esthesios, sinonasal squames, neuroendocrines, melanomas, Ewings, basically everything basaloid and rhabdoid. And within the thorax, 15 tumors, 12 pulmonary, and 3 thymics. So make it short, from this cohort of 256 cases, we were able to find out 4 tumors which were reclassified as INI1 deficient carcinomas. All 4 these were located within the sinonasal tract. So probably the conclusion was that these tumors tend to be restricted to the sinonasal tract, and their unique morphology, clinical picture, as well as the unique phenotype warrant separation as a these as separate entities within the high-grade sinonasal tumors. So what's another important thing, separating the SMART1 deficient tumor may provide a novel therapeutic approach for these patients. We don't know yet. So this is an example from our series. One case which was initially diagnosed as a basaloid or a non-keratinizing squamous carcinoma, so complete loss of INI1. And another cool case was a young lady which initially diagnosed with as a malignant diversal tumor, low power, has this classic microcystic appearance, which is always good for embryonal or endodermal yolk sac tumor. And that was actually what swayed the original pathologists to diagnose this as a malignant germ cell tumor, along with diffuse positivity for SALL4. SALL4 is a very good marker for germ cell tumors, so that's always used, for germ cell elevation tumors. Anyway, interesting. This tumor had also this papillary basaloid component, and again, where the cells with very prominent nucleoli. You can see here with a huge perineural invasion. And this is the INI1, which was completely lost. So this case was in retrospect reclassified as a SNUC1 or INI1 deficient sinonasal tumor. Just a word of caution, if you are using in general tissue microarrays for screening for your studies. So for instance, this was a TMA which we had for small round blue cell tumors with a garden variety of the Mr. Sleep pathology, so everything, peanut, rhabdos, olfactories, and so forth. So within those TMAs, we thought we fished out another two INI1 deficient tumors. The morphology fitted, again, prominent nucleoli, very nice like SNUC appearance. This was actually classified the original diagnosis as a neuroendocrine carcinoma, had the smudging effect. But anyway, so on TMAs, complete loss, they were negative for INI1, so lost. If you go at full sections, then you'll see there is only a partial loss. So again, illustration of tumor heterogeneity, and you have to use the TMA tools as with caution. So always, if you'll have it lost, if you see it lost, then always it's advisable to go at the full sections to be completely assured that indeed there is complete loss as not just partial loss. So illustrating again the tumor heterogeneity. That was the point. So just in a nutshell, some of the cancer-related effects of SMARCB1 loss. P16 downregulated goes along with upregulation of cyclin B1 and E2F. Again, the interferon is downregulated, and here comes, as a potential therapeutical approach, possible interferon administration. I don't know. These are really not that many cases, and I don't think there has been anything tried so far. So since we are approaching dinner time, so how about, how would you like to be sequenced, right? So many tumors, so many options. You have deep whole genome sequencing, deep whole exome arrays. So there you go, SMARCB1. How would you like to have it sequenced? Anyway, and I'm gonna end up with the last and my favorite type of tumor, actually the teratocarcinosarcoma. I guess we had a couple of cases with Anderson, yes. So these are high-grade malignant neoplasms with really complex histology. They combine the features of teratoma and carcinosarcoma, so you'll find both benign and malignant components from epithelial, neural, and mesenchymal lineage. But classic germ cell tumors such embryonal carcinomas, chorios, and seminomas are never absent, so you shouldn't see the classic germ cell component. So a low power of teratocarcinosarcoma, so you would notice the primitive neural component here. The epithelial elements are present either in the form of squamous or a glandular component. A very good tip-off for pathologists is finding this type of fetal oral mucosa. So basically squamous nests with clear cytoplasm, lots of glycogen. So we call this the fetal type oral mucosa. Whenever you see this, I mean, that's a very, very good tip-off, and start looking for a teratocarcinosarcoma. Neural elements are present in the form of rosettes and pseudo-rosettes, or a more primitive component similar to a blastoma, small blue cells. The mesenchymal elements with a cartilaginous component illustrated here adjacent to the primitive neural component, or rhabdomyoblast component, for instance. That's a sign, a classic sign of broken arrow rhabdomyoblasts. First described in 1984 at the AFIP by Hefner and Hyams. Majority of these cases occur in the sinonasal tract. However, isolated reports have been described in nasopharynx and pharynx as well. This was a review from Anderson, from Dr. Mario Luna, which gathered 63 cases. There is a predominance of male to female ratio 8:1, with a mean age of presentation being around 61 years. Majority of these cases, as I said, confined within the sinonasal tract, mainly the ethmoid and nasal cavity, followed by nasal cavity by itself, or ethmoid sinus by itself, and a few cases within the maxillary sinus. Scattered cases within the nasopharynx, pharynx, and one case in the oral cavity. Profile for the primitive cells, CD99 and S100 always helpful markers. The mesenchymal component, obviously bimentin. Plasmin for rhabdos, for the rhabdo component. Myogenin, again for the rhabdo and SMA. Neuroepithelium with neural markers such as NSC, synapto, and chromogranin. Keratin for the epithelium. In terms of prognosis and treatment, these are highly malignant tumors, mean survival about 2 years. Most of these cases will recur within 3 years, and in terms of management, complete resection and followed by radiotherapy. That's the management. Obviously, a differential diagnosis, sampling is paramount. If you don't sample it, you will definitely miss it. Main differential diagnosis will be with a carcinosarcoma, which will have a malignant carcinomatous part and a malignant sarcomatous part. Germ cell tumors such as seminomas, embryonals, chorios, and yolk sac tumors. Teratoma, which obviously will lack the malignant. Like I said, sampling is paramount. If you don't sample it, or small biopsy, it's very easy to go down the drain along with the wrong diagnosis. So like any small round cell tumor such as olfactory neuroblastoma, or a squamous carcinoma, neuroendocrine, adenoma, and sarcoma. So to conclude, tips off for this type of malignancy. At low power, you'll have this classic teratoid appearance with epithelial, mesenchymal, and neuroepithelial component. The epithelial component will show the fetal type squamous nests or glandular structures. The primitive cells can be seen under the form of rhabdomyoblast, chondroid component, or more So a very systematic approach to the undifferentiated sinonasal tumors divides them into epithelial and non-epithelial. The non-epithelial component divided by itself into neuroectodermal tumors with olfactory neuroblastomas, hematuins, and melanomas, the hematolymphoid tumors with extramedullary plasmacytoma and extramedullary myeloid sarcoma, mesenchymal tumors, rhabdomyosarc, mesenchymal chondrosarc, always on the back of your mind. People tend to forget about the mesenchymal chondrosarc. Synovial sarcoma, and on rare occasions, the desmoplastic small round cell tumors. And back to our subject of today, the epithelial undifferentiated sinonasal tumors with SNUC, including the INI1 deficient carcinoma, nasopharyngeal type undifferentiated carcinoma, the NUC carcinoma, neuroendocrine small cell type, and variants of squamous carcinoma, including the basaloid and adenoid cystic like carcinoma. So this was the consensus for the WHO, which was held in Lyon a few months ago. So this was our sinonasal group. You may recognize Lester Thompson. Now he has a short haircut here, but so that's Bruce Wenning, also very prominent icon head and neck pathologist. And that's Pete Slotwijk from Netherlands. You may know him, I don't know. No? That's one. Anyway, so the skull-based team, I don't need to acknowledge. I guess you all know all these people. So I thought always I enjoyed when I went to MoMA in New York, seeing this the portrait of Dr. Wilhelm Meyer Hermann. How often do you actually see a portrait of ENT doc, right, in a museum of art? So that was Otto Dix, the painter. He donated this to MoMA. And it's been said that kind doctor emigrated to the States in 1936 and was spotted several times in front of his own, portrait, and had to hear the jokes about his silhouette and so forth. So anyway, I like this from Otto Dix, trust your eyes, and this is very valid for pathologists, always trust what you see. So thank you.